Okay, welcome everybody. This is Mad Medicine with Miss P, and today we're going to do vital signs. I think it's safe to say that you all know how I feel about vital signs, being that they're all vital and stuff. It's really important that you understand them. If you would tag your CNA friends in here also. Any of you nurses that work with your CNAs that maybe need a little update on vital signs, that now would be a good time. It's really important that we stop allowing them to allowing everybody, not CNAs, but everybody in general, recording vital signs that are not viable, and that they need to know what these numbers mean. And it's real simple. This will be probably a pretty short video. Obviously, it's not going to include blood pressure, otherwise it could be a 2-hour video. That will be next Tuesday. We're gonna hit blood pressure pretty hard. In case you haven't noticed, hi, have we met? Yes, I'm Miss P, and we're going to drill blood pressure into y'all like a jackhammer. So again, I just wanted to kind of give a little heads up here. I apologize. There's no editing, there's no fixing anything. So to Emily's horror, I only have an Android. I don't have an iPhone. I don't have a computer. I have no intention of getting either one of those. So just so you know, if I spit when I talk or mispronounce something or boob pops out or something, you're gonna have to roll with it. Just roll with it, because that's what I'm gonna do. And I'm certainly not gonna redo this whole video if I screw something up along the line. You're just gonna have to recognize I am in fact human, despite popular belief. It's true. So I'm gonna make mistakes like everybody else. So just bear with me. But I really want you guys to try to learn as much as you can. I want to just try to make the school process and the learning process when you get out there and start working as easy as possible, because I know you're going to come across some stuff that is a little confusing, and I still do. I still hear the anesthesiologist talking at the desk about, they were on call this weekend and this is what happened, and I'm kind of like, excuse me, what's that word? I've never heard that before. And when they don't, when they're not busy, I will run back and ask if I can, or I'll try to look it up, because I'm always trying to learn, and I want to know what's going on. So the vital signs is a good place to start. It's really important that you understand what these numbers mean. So we're going to start with temperature. Real simple, real basic. Y'all, stop writing down ridiculous temperatures. Okay, it's physically killing me. And I don't understand what you don't understand. Our core temperature is 98.6. You don't have to like it. You don't have to agree with me. You don't even have to uh, prove it. If forensics, still to this day, forensics uses about 98.6 to determine time of death in general, then that's basically our core temperature. And I know people out there run a little low, and I always have a patient that's like, oh, what was my temperature? I run a little low. And a little tiny part of me is really tempted to say, how about you bend over and let's test that theory, because I'm going to bet if you get core temperature, that means skin on skin, deep, with that piece of crap digital Welsh Allen thermometer that has a sheath on it thicker than my fake press-on nails. I'm telling you that's not their core temperature. Or if you're trying to take the temperature of a little old lady who's 80 pounds soaking wet, she's 110 years old, and her meat doesn't even touch, and you're just kind of resting it in the air surrounding her armpit, yeah, that's not an axillary temperature, okay? If you're going to check it under their tongue and they're a big mouth breather because, again, they're 100 years old, lying in bed, staring at the ceiling all day, that's not a core temperature. So if you're getting something under, I'm gonna go out on a limb and just, I'm gonna give you 97.0. That's really, still, I call BS on that, but I'm sick of fighting the good fight. So I'm just going to tell you, anything under 97.0, it's the temperature of a corpse. Okay. It's when y'all chart 95.5, that lady's been dead for a while, and someone missed it. Someone at their job is not paying attention. Somebody is taking the temperature of a corpse, and I don't know how you missed it. So that is not a viable temperature. That's like 3 degrees below normal. So would you chart 3 degrees above normal and not do anything about it? Would that be okay? Is that like a normal thing? Would you think that that's a safe bet? It's not. So stop writing down ridiculous numbers. If you find that when you're taking these temperatures, you're not getting something accurate, check it again, check it again, check it again. Isn't that what I always say? Check it 3 times. And by the 3rd time, you've either cured the problem, or you have a real problem. Now we need to do something about it. Don't think these people that have dementia and Alzheimer's and significant brain diseases are not going to go into hypothermia due to poor thermoregulation. They have no adipose. I've seen you poor CNAs. You got your scrub pants pulled up to your knees. You're hiking your sleeves up as much as you can. You're still pouring sweat. It is 100 degrees in their room and they've got 3 blankets on and don't want you to uncover them to give them a bath. I understand. That is poor thermoregulation and it needs to be recognized, charted, noted, and maybe even treated. So pay attention to these temperatures. I know you kind of skip over them and they're not really, you kind of feel like, well, they're not hot to touch and they're not, ice cold. So it's a number you just write down and kind of move on. And, but blood pressure is much more important, or heart rate is much more important. Temperature is important also. And I kind of learned this maybe 15, 20 years ago. So when the CRNA comes and puts that patient in my slot for recovery and she wants a temperature and some other nurse maybe helping me out glides the temporal thermometer all over their freezing cold forehead because it's like 14 degrees in the OR. So cold, I can't touch the plastic chart they bring me. I leave it on the counter till it warms up in the freezing PACU, right? So they're trying to help out and they kind of glide it all around their forehead and they're like, 96.2. The CRNA looks at me like, could you give me a number I can write down? Because I can't write down that number. Why can't you write down that number? Whose job was it to keep that patient warm during the procedure under general anesthesia? And she knows that's not a real temperature because they had the CO2 monitor that's inside their trach telling you what temperature they are. So they know that that's not a real thermometer reading. So if you've got that, now we've got all the no contact ones and those are actually better. That red infrared dot, that you can glide all around the thin forehead skin if you want to, or you can just skip all that mess and point it at the big giant carotid artery right here, because that infrared dot is testing the temperature of the blood. So you can look for your little tiny temporal artery if you want to, or I just go to the giant one right here that is often throbbing before anesthesia and surgery because the patients are already nervous, and I never get a ridiculous number. It doesn't happen. You have to know what your numbers are. You have to expect reasonable numbers. And if you don't get a reasonable number, then check it again, check it again, check it again. And if you continue to get an abnormal reading or something you think is not okay, then do something about it. As a nurse, talking about CNAs and as a nurse, you guys always want to chart, like as a student, you always say nurse notified. So what happens when you're the nurse? What are you going to do? Who are you going to notify? Do you want to go in there and assess them first, right? What I always say, assess, notify, and treat. Assess the patient first. Are they feeling feverish if you've got a higher temperature? Are they feeling cold? Are they clammy? Do they have chills? Are they, cool to the touch? Are they uncovered and they're not capable of completely covering themselves up and it's chilly in the room? So you have to assess the patient. You're already at the bedside, assess that patient. After assessing the patient, then you may need to notify somebody. As a tech, you're going to notify your nurse. Hopefully she'll do something about it. As a nurse, you're going to notify maybe the NP or the doctor, depending on what you find. Or you might even notify another nurse, maybe your supervisor. And as a whole, you kind of go in there and kind of decide, is this something we need to tell the doctor about, or is it something we can fix on our own? Same thing with your hyperthermic patients. When you go in there and they're like 100, 0.6, I know your standing orders say toss some Tylenol at them, and I'm not saying not do that. But you also have to recognize, why do they have a fever? You cannot just give them some Tylenol and that cures their fever and the problem is solved. What spiked a fever in the first place? If I was at home and suddenly got a fever, I wouldn't be like, oh, I'll take some Tylenol and call it a day. I'd be like, whoa. What do I have? What did I get? What's happening? Well, where would I just suddenly get a fever? Babies with their teething and their explosive diarrhea, they get fevers and you kind of give them some Tylenol to keep an eye on them, sure. But adults on average don't normally do that. So if you have 2 degrees below normal, you need to assess it. If you have 2 degrees above normal, you need to assess it. And you need to treat it, to do something about it. And it's not just Tylenol. Find out where the fever came from. Start assessing them. Ask the tech about the urine. How many times have they soiled their brief? Or if they're going to the bathroom, are they going frequently? If the patient's awake, alert, and oriented, ask them about it. Do they have frequency, urgency, burning with urination? Find out where that fever came from. Maybe listen to their lungs. Ask if they've had a cough. Find it. Nurses don't just babysit people until they die. Those are babysitters. I say that all the time, right? So you give your babysitter, you plan to give her, 20 or 30 bucks at the end of the night. And you're like, you have one job. Keep my child alive while we go out for dinner, right? That is not what nurses do. Nurses make patients better. We're detectives and we find what's wrong with them. We fix it on our own, or we call for orders and get the doctor or the NP involved to try to fix this issue. Don't ignore the small signs. When your tech comes to you and says, Miss Smith isn't the same, she was yesterday. She's kind of a little bit different. I'm kind of new here. I don't know her very well, but I know something's up. Go check it out. It's really important that you detect. You have to go in there and assess. As a nurse, you really want to try to find what the problem is, and hopefully there's no problem, and maybe you're making something out of nothing. Good. I rather make a big old stink and find out nothing's wrong than miss it. In these skilled facilities, or even at home, y'all know how I feel about this. When patients are sent to the hospital with 24-hour nursing care for dehydration or urosepsis, that's really not okay. Those things don't happen overnight. They accumulate over a period of time. And I know how y'all feel about it. You pass ice at 2:00, right? We're going to pass ice. We get our little cart and our little ice trays and their pitchers, and we're going passing ice. And what do you do first? You pour out the full pitcher of water into the sink in their bathroom, and then you fill it up again. You can pass ice all you want, and you can make sure they have something to drink at the bedside. But if you're not in there sitting them up and holding the straw, they're not going to drink, and they're certainly not going to drink their 8 glasses a day that you and I drink, right? Of course, that's right. If you're not doing that, you're part of the problem. Just hydration alone will significantly stop the risk of them going to the hospital with dehydration or even urosepsis. Check for bladder distension. Get them in a position where they come completely empty. If you're asking a male patient to use a urinal and asking urine to go up their ureter and then back down, and you think they're going to completely empty their bladder, not leaving a little in there, which is stasis, which is a warm, moist environment inviting infection, then you don't understand physics. That's all I'm going to say on temperature. If you got questions, ask. Okay, so we're going to move on to heart rate. Not so much rhythm. We'll touch on rhythm a little bit, but heart rate. As we all know, anything between 60 and 100 is what we're looking for, right? So even if they're bradycardic, you still have to assess them. If they're 59, go in there, poke them in the eye, flash them, stimulate them, do something, get it to 60. If you cured them, you don't have to write a note. How critical could it be if just doing a little something got their heart rate back up, right? But if they're significantly bradycardic, or if they're symptomatic bradycardic, even if 58 and they are diaphoretic and they're lethargic or dizziness, malaise, whatever you think that they've got going on and they are bradycardic, then you need to assess, notify, and treat and see what we can do about that. But you have to recognize those numbers. I see a lot of student nurses, even in third term, charting S1, S2 audible with a regular rhythm at 58 beats per minute. That's maybe regular, but it's still bradycardic. You have to recognize that as below normal, let's say, right? Maybe they're a runner. I get a lot of patients in that their resting heart rate is in their 50s, sometimes even 40s. We even had one, I told you all about this, that one resting heart rate was 37. Yeah, getting ready to have surgery. And I'm like, excuse me, you okay? And that patient was completely okay. We still had them go down and get checked out. They went to the heart center, they got checked out, everything was fine. Maybe, can't remember, they were a runner, a marathon or whatever. And we came back and they were able to have surgery, no problem. That was the resting heart rate. They were completely asymptomatic and that was okay. But you have to recognize it first as an abnormal and then assess, notify, and treat. And that's exactly what we did. And then the patient went on and was able to have their surgery, no problem. Anything, of course, above 100 is not okay. Now, I don't know why you all can't remember this, because when I ask you, y'all just go blank. I hear crickets. When you have a heart rate, a resting heart rate of 106, 110, anything like that, what's the quickest, easiest way to see if we can get that better? All right, yeah, good. Valsalva. You have them bear down, cough, do anything to try to get it better. And if you can get it better, they drop it to 98 and it stays at 98, write it down, move on, problem solved, you cured them. If not, and the resting heart rate is still tachycardic, well, then you might have to do something about it. Find out why. Are they dehydrated? Check their blood pressure, see if they're dehydrated, see what we can do about it, maybe even notify somebody if need be, but recognize that number as not okay. Are they an AFib, and is it going to consistently change, and you see it 98, 110, 86, 104, and that sort of thing, and they may live there, and that's okay too. But still assess the patient, which means you need to know what the signs and symptoms of tachycardia and bradycardia are, right? Think about how you would feel with your heart beating out of your chest. So if that is a resting heart rate, stop checking their heart rates after they've walked to the bathroom and back. You know they're terrified of falling. They're holding their breath. They're holding on to things as they go. They plop down on the toilet and they're like, and then they do their business. And then when they get up and walk back, they plop down in bed and do the same thing. That is not when you check their respirations and their heart rate. Don't do that. That's not realistic any more than you're going to ask me to run around the block for a little while and then check my vital signs. First of all, I'm never going to do that. If ever you see me running, you need to run too. I've never run in my life. I don't ever plan to. So that's just a heads up right then and there. Don't even look behind me. Just start running also. So with your heart rate, you have to recognize that if there's something abnormal, you need to do something about that number. Anything below 60, anything above 100. We're going to keep this real basic before we get into rhythms down the line. Now, when you're listening for their heart rate and you're checking the rhythm, it's not just about a number there, then it's about rhythm, right? And like I always say, you have three choices. This isn't so much when you immediately do their vital signs and you're just kind of getting some numbers. Let's say this is before we give meds and you need to listen to their rate and rhythm, right? You're listening for that rhythm. You have one of three choices. You have regular. That means that heart rate is, that beat is just like yours and mine. You're listening to it. You can tap your foot to it. You can beat your head to it, and you're kind of on it and you're nodding and you're moving along. And you're like, okay, that's pretty rhythmic, right? Just like yours and mine, ba-bum, ba-bum, ba-bum. Pretty simple, right? That's regular, and you listen for a full minute. Your next option is regularly irregular. It's abnormal, but it's consistently abnormal. Bump, ba-bum, bump, bump, ba-bum, bump, bump, ba-bum, bump. And you're going to hear that throughout the entire time. It doesn't make it necessarily normal for you and me, but it's normal for this patient, for whatever their history is. It's viable. It is effective. It's not treatable. It is a acceptable rhythm, and it's regularly irregular. And you'll find that a lot. Even when we print them out, I see a lot of sinus rhythms with an arrhythmia, sinus rhythm with pauses. That doesn't mean it's a problem. It just is what it is and doesn't necessarily require treatment. So recognize those rhythms. And then your last one is irregularly irregular, right? There's no rhyme or reason. You can't beat your toe to it. You can't tap your toe to it. You can't nod your head to it. You can't count it. You have to start all over, and you kind of get lost in the count, and then it's up, then it's faster, then it's slower, then you missed one, and it's tricky to follow along. It's generally AFib. It could be something else, but on average, it's generally AFib. That's irregularly irregular. Michael Jackson himself couldn't dance to it. So that is probably, if it's not in the history and you don't see anything about it and the patient says, no, I don't have any heart problems, that is reportable. You're going to drop what you're doing right here now and go do something about that. Go tell somebody that this patient probably just jumped into AFib, and if they jumped in, they could jump out, and what is the risk, right? What is the risk with AFib? I'm asking you students, right? What is the risk with AFib? If a patient jumps into AFib, that is the atriums quivering uselessly. So blood is going to pool, and pooling blood can clot. And a clot can wiggle out of that atrium into a ventricle and shoot out to one of three areas where we don't want them, right? Brain, heart, lungs, right? So that's your CVA, that's your MI, and that's your PE. Those can all be deadly. That's why AFib is so important. So stop charting irregularly irregular and act like it's okay. And if I look in the history and don't see anything in there about AFib or any history of an arrhythmia, that's not okay. That is a reportable thing, and you need to do something about that immediately. Okay, so that is your temperature, that is your heart rate, and now we're going to talk about respirations. Okay, so respirations are a little tricky. I know your books are going to tell you, the elderly with your temperature run a little low, and and some respirations in your book will say, like, anything under 10 you're going to want to assess or be concerned about. That's not always entirely true, and I only know that from experience, especially these little cataract ladies. We bring all these patients back to get ready to have cataract surgery, and they are in their 80s. They have been through literally world wars, these men, so they have been through enough. They are not nervous about surgery. They're not flipping out. They're not freaking out. They are lying still, and they are happy to not be nagged or not to have something to do, to maybe get a little attention, and they're lying flat and they are comfortable, and we're making conversation, having a good time. And I look over and the respirations say 9, sometimes even 8. And I'm like, okay. And they're completely okay. There's no assessing to do. We're talking to them and they're doing just fine. All their other vitals are okay. Those numbers don't scare me too much. Now, after an opioid, after, a narcotic, maybe some pain medication, maybe just after a general anesthetic or anesthesia or sedation, yes, then I might be a little concerned. But don't let those numbers scare you too much. Always assess the patient and recognize if they are breathing slowly and deeply, it's going to be a little bit of a lower number in that full minute than it would be if someone's panting. I'm much more concerned when y'all come back and you're like, respirations are 32. Have you tried to breathe 32 times in a minute? It's panting. It's literally panting. That is not okay. Those patients are breathing so shallow and so quickly because they have pleurisy or pleural effusion or something significant going on, or they're in end-stage COPD where they have no lower lung at all, and they're using the little bit of alveoli left in their upper lobes because their rip roaring emphysema is just shot. And they're on 6 liters despite being COPD, and their SAT is still 92 at best. That is a different story. So you have to really look at the big picture and recognize what that number means. And also, a lot of times these older patients, or some patients may be looking for a little attention or a little, one-on-one. Ask them to breathe slowly and deeply. And if they're capable of doing so, well, then that original number may not have been a realistic number. So make sure you're realizing and recognizing how these numbers correlate, and always assess your patient. I don't care what the monitor says, I'm going to immediately assess my patient. Even if I'm getting vital signs just before surgery and their heart rate is jumping all around, I'm going to go straight to the radial pulse and check it and look at that number at the same time and making sure that that is correct. And maybe they are an AFib and they have a history of it, and that's okay. I know y'all think that, someone's an AFib, we need to, jump on them and do something about them. People are at work right now in AFib. People are on the golf course right now in AFib. That's okay as long as they're being treated, right? They're going to have an anticoagulant. They're going to have some sort of antiarrhythmic, right? So that's not a problem. And sometimes they can't even have those for certain reasons. So don't let it freak you out. Just recognize what it is. So that's your respirations, and that's really all there is to it. If someone's breathing quickly and shallow, they have a pulmonary problem, and recognize it. And I've had that happen. I've had a student come to me before, and they're like, her respirations are 32. And I, kind of like, oh God, all right, let's go look. So, I get my little stethoscope and I get ready to go in there. And, or they'll say they did their assessment, and with their breath sounds, they also heard a rub. And I'm always like, okay, we know it's wrong. You didn't hear rub. Is the patient in tears? Are they crying? Are they, they freaking out? Are they, afraid to breathe? So I go into this one student who told me, they thought they heard a rub, and their, rate is, in their 30s or